Hi everybody, it's good to see you all. I think Dr. Corey did a great job kind of summarizing the options. I'll obviously focus mostly on the surgical aspect and thinking about the timing of when and how. So the first thing that I'll say is, a lot of what I'll talk about is in the context of having thyroid eye disease. So as Dr. Corey mentioned, we know that with thyroid eye disease, thyroid surgery is a pretty good approach to try to prevent it from getting worse. And in terms of when does it make sense to do that, for most patients it is early on in the process. As Dr. Kahana mentioned, your fluctuating thyroid hormones can exacerbate or worsen eye disease. And we know by getting rapid control of your TSH, we can prevent your eye disease from getting worse and having more permanent changes. So this was a study that was done that looked at basically the difference in if patients have thyroidectomy early on in their course versus if it's delayed a year or two. And basically what these graphs show is that patients who have early thyroidectomy had more rapid resolution and more quick time to euthyroidism or stable thyroid function tests. So in the setting of thyroid eye disease, that's very important. Oh, thank you.
Thank you.
Another thing that's very important is if you look at the early versus delayed thyroidectomy group, patients who have early thyroidectomy tend to have less complications. So we'll go a little bit through the complications and risk of thyroid surgery, but the risk after being on thyroid medication for a long time and all of that inflammation over time can be much more significant. So we always do recommend early thyroid surgery for Graves' disease, especially in the setting of thyroid eye disease. Something that will come up often is how your thyroid function needs to be prior to surgery. So we used to think that every single patient had to have perfectly controlled thyroid levels prior to thyroid surgery, or they were at risk of going into something scary called thyroid storm, or having really unstable blood pressures and heart rates in the operating room. We now know that a lot of patients who don't have control, which is mainly the reason to do surgery sometimes, actually don't have a higher risk of those problems in the operating room. So previously we used to say, oh, your thyroid levels have to be perfect before surgery, and that can make patients have their surgery delayed for months. But now recent studies have shown that even uncontrolled patients can have safe thyroid surgery if done by an experienced surgeon at a hospital where we've seen a lot of this. So ideally, we'd like to have you have normal thyroid function tests, but that does not preclude the ability to do thyroid surgery safely. So I want to talk a little bit about practically what thyroid surgery would look like. So this is an open or traditional surgery, so that does mean that you will have a visible scar. Typically, it's about 4 to 6 inches. Centimeters are about 3 to 4 inches. We try to hide it in a crease. In this example, you can kind of barely see the result of surgery. But obviously, the size of the scar will depend on the size of your thyroid, so it might differ for different patients. It's typically one-night stay in the hospital. Some patients at other centers will go home the same day, but for Graves' disease, I think it's very important that you stay a night in the hospital, and we'll talk about why in a minute. As Dr. Corey mentioned, this does mean that you'll require Synthroid for the rest of your life. And typically we start that on the first day after surgery, but if you're very, very hyperthyroid prior to surgery, we might wait actually 3 to 5 days to start that medication. The recovery process is actually pretty straightforward. Typically we just recommend that you don't do any strenuous activity or heavy lifting for about 2 weeks. And most patients are returning to work around 1 week, so I can completely agree with Dr. Corey. If you tell me you want to take out 2 weeks, that's fine. So why don't you take it for yourself? That's completely okay. So the risks of total thyroidectomy. So we'll talk about this first just in general, and then we'll talk about it specifically in the context of Graves' disease. So as you can see on this picture to the screen right, the thyroid is connected to a lot of important things. There is the carotid artery, the jugular vein, the nerves to help control your voice box, the parathyroid glands which help regulate your calcium levels. So all of those structures can be at risk during the surgery. The main risks that I think about, I tell patients there are kind of 4 risks. The first 2 are common to all surgery. There's always the risk of bleeding or always the risk of infection anytime you make a nick in the skin. Bleeding, if it tends to happen, manifests itself in the first 24 hours after surgery, which is why I think it's very important to stay in the hospital. Especially for Graves' disease, we know the risk of bleeding is higher. So if you're at the hospital and that happens, I can take you back and fix it. If you're at home, you can run into a problem. So that's why for Graves, I think it's very important to stay overnight. Infection, we rarely see infections with thyroid surgery. The neck is a clean area. It's not like moving a colon or a gallbladder. So wound infections are possible, but we probably see that 1 or 2 times a year, so pretty rare. Damage to the recurrent laryngeal nerves. We have 2 nerves that run up right behind the thyroid gland and they regulate your voice. Those can always be damaged or stretched. It can result in either temporary or permanent changes to your voice. The risk of a permanent change to your voice with an experienced surgeon is about 1%. A temporary change to your voice is about 5%. Most surgeons, and all of us at the University of Michigan, use nerve monitoring, which is a device we can use in the operating room to let us know where the nerve is and ensure that it's working throughout the entire surgery. So I think it's very important to also ask your surgeon if they use nerve monitoring. Lastly, the parathyroid glands are these glands that you have four of that live behind your thyroid and regulate your body's calcium. And those can always be damaged during surgery as well, which can result in the need to take calcium supplements for the rest of your life. Due to the inflammation for Graves', it's actually very difficult to carefully separate those glands. Those glands are about the size of a grain of rice. So we see very often temporary low calcium, especially after Graves' disease. I would say probably 60 to 70% of patients after thyroidectomy for Graves' disease require calcium temporarily. But to require calcium permanently is only about usually 2 to 3% of patients. So the risks of thyroidectomy in Graves' disease is a little bit different. From all the inflammation, we know that the bleeding risk is higher. So in all patients, we think the risk is about 1.9%, but in Graves' disease, you see that risk is about 3%. So obviously that's nothing too drastically different, but I think enough to certainly warrant a night stay in the hospital. You'll see that the rate of infection or vocal cord issues are about the same for Graves' disease and for non-Graves' disease. But when you look at calcium issues, that rate increases to about 12.4% for people with Graves' disease, as opposed to 8.8% for people getting their thyroid removed for other reasons. So there are things that we can do to help mitigate those risks more for patients with Graves' disease. The first one, in terms of bleeding, like I mentioned, we keep you overnight in the hospital. We can actually give you iodine about a week before surgery to help decrease the vascularity of the thyroid gland, which can help decrease the risk of bleeding a little bit. Calcium, like I mentioned, most people with Graves' disease after thyroid surgery will need to be on it, but we make that process a little less symptomatic by really loading you up with calcium the week before surgery and ensuring that your vitamin D levels are normal before surgery. I agree with Dr. Corey completely. One of the most important things for thyroid surgery, especially thyroid surgery for Graves' disease, is making sure that the surgeon that you see is someone who only does thyroid surgery. Myself and all my partners in practice is dedicated to thyroid, parathyroid, and endocrine surgery. If you're meeting with the surgeon, I think you should ask them, how many of these do you do? How many of these have you done for Graves' disease? And if you don't get an answer that makes sense, or they don't want to answer the question, I think you should consider maybe talking to a different surgeon. This is a study that kind of looks at the different complication rates between low volume and high volume hospitals. So we know that if a hospital, meaning all the surgeons there, do greater than 47 thyroidectomies a year, the outcomes are better. I can tell you, as a group at the University of Michigan, we probably do between the 5 of us about 100 a month. So I think that's 1,200 a year, something like that. So again, a high volume experience of the center is really important. So this is me and my partners. Like I mentioned, we all do a lot of endocrine surgery, and we're more than happy to see you in Ann Arbor, and I'll be around to answer any questions you might have.